Among lipid-lowering agents, statins are by far the most popular drugs. To explain their mechanism of action, we have to know cholesterol synthesis. Initially, from 2-acetyl-CoA molecules, we make acetoacetyl-CoA. After this, we add to acetoacetyl-CoA another acetyl-CoA, which results in formation of HMG-CoA. HMG-CoA is converted by the major enzyme in cholesterol synthesis, HMG-CoA reductase, to mevalonic acid. It's the most important reaction in entire cholesterol synthesis. Mevalonic acid undergoes further condensation that results in formation of farnesyl pyrophosphate. From 2-farnesyl pyrophosphate molecules, we make squalene. Squalene undergoes conversion to lanosterol, and from lanosterol we make cholesterol. To deliver cholesterol to peripheral tissues, liver packs cholesterol together with triacylglycerols into the lipoprotein, and the final result is the production of a very low-density lipoprotein particle. By the blood, very low-density lipoproteins deliver triacylglycerols to peripheral tissues. After the delivery, the size and the composition of lipoprotein becomes different, and now such particle is called intermediate density lipoprotein. Once intermediate density lipoproteins deliver triacylglycerols and cholesterol to tissues, again the composition and the size of the particle becomes different, and now such particle called low density lipoprotein. In context of our discussion, low density lipoproteins have two pathways. The first pathway is to be eliminated from the blood by the liver tissue via LDL receptor, and once liver uptakes LDL particles from the blood, LDL particles undergo degradation to cholesterol, triacylglycerols, and proteins. The second pathway is the reason why we consider LDL particles dangerous, because in oxidized form, LDL particles can accumulate on endothelial cells in the blood vessels, which results in atherosclerosis. The less well-known feature in cholesterol synthesis is that we use farnesyl pyrophosphate for production of coenzyme Q, which is one of the components of electron transport chain in mitochondria. The major function of mitochondria is energy production, so the highest demand for coenzyme Q have tissues with the highest metabolic activity, and it's liver tissue and muscle tissues, because every muscle contraction requires energy. The direct mechanism of action of statins is inhibition of HMG-CoA reductase, but also statins have indirect effect, which is stimulation of LDL receptor recycling. These two effects combine cause decrease in cholesterol concentration in our blood, and exactly this feature explains why statins can significantly lower the mortality in patients with cardiovascular disease. So let's explain them. Statins inhibit the activity of HMG-CoA reductase. If this enzyme stops working, liver cannot produce mevalonic acid, so subsequently the production of all other intermediate metabolites in cholesterol synthesis decrease, and eventually the production of cholesterol itself decrease. With decrease in cholesterol production, the formation of very low density lipoproteins decrease, which leads to decrease in triacylglycerols in the blood. With decrease in VLDL production, the concentration of IDL and low density lipoproteins decrease, because these particles are formed from VLDL. But also there is indirect effect. The concept is that such highly metabolically active tissue like liver needs a lot of cholesterol, because without cholesterol, hepatocytes cannot even form cellular membranes. So decrease in cholesterol production in the liver tissue activates compensatory mechanism, which provides increase in activity of LDL receptors on hepatocyte surface. And the higher the activity of LDL receptors, the higher the uptake of LDL particles from the blood. The final result of this compensatory response is decrease in the amount of LDL particles in the blood, and in the same time, increase in amount of cholesterol molecules inside the liver tissue. And because LDL particles cause atherosclerosis, with decrease in concentration of LDL particles, the rate of atherosclerosis progression decreases. So, the major reason why statins are so effective in correction of LDL is their ability to stimulate LDL receptors. And because low-density lipoprotein particles are the major carriers of cholesterol, it explains why statins are so popular in patients with high cholesterol level. Also, because statins to some extent decrease the LDL production, they can lower triglycerides level in the blood. But for exams, we have to know that statins have two well-known side effects. It's hepatotoxicity and myopathy. So let's explain their pathogenesis. As we see, with inhibition of HMG-CoA reductase, the production of all intermediate metabolites in cholesterol synthesis decreases, and one of such metabolites is farnesyl pyrophosphate. The problem is that with decrease in farnesyl pyrophosphate, the production of coenzyme Q decreases, and because coenzyme Q is essential element in electron transport chain, decrease in coenzyme Q production leads to mitochondrial dysfunction. Mitochondrial dysfunction causes severe oxidative stress, which leads to cellular injury. And cellular injury, in combination with energy deficiency, leads to hepatocyte death. With death, hepatocyte cellular membrane becomes disrupted, which leads to release of intracellular enzymes as ALT and AST into the blood. Exactly this process occurs in the muscle tissue. Energy deficiency in the muscle tissue manifests as muscle weakness and myalgia. If injury is very severe, this can cause death of myocytes, a condition known as rhabdomyolysis. And the marker of myocytes injury is elevation of creatine kinase. So, the reason why liver and muscle tissues are the primary targets is their high metabolic activity, because statins cause mitochondrial dysfunction, and once mitochondria becomes injured, cell won't be able to produce energy, and the higher the metabolic activity, the higher the energy demand.